Welcome to Prism Rounds, where we break down one study at a time. I have to admit, I walked into the recording booth today with a very specific emotion regarding this paper.
Usually you walk in with caffeine-induced anxiety or, post-call exhaustion. What is it today?
It's guilt. Genuine clinical guilt.
Guilt. That is a heavy way to start a deep dive.
It's the Monday morning aspect that's the problem. You know the drill. I'm standing in the ICU. I have a patient, let's call him Mr. Martinez. He's 56, recovering from acute tubular necrosis.
Your bread and butter AKI case.
Totally. And he's getting better. He's eating his breakfast. He's probably complaining about the hospital food. He's texting his wife. He's extubated. But his creatinine is still 4.0.
Okay.
And because it's Monday and because the calendar says Monday, Wednesday, Friday, I put him on the dialysis machine. I don't really think about it. I just... I do it. And the trial we are discussing today, LIBERATE-D, is basically telling me that my autopilot might be hurting him.
You're talking about that friction between workflow and physiology. We dialyze on Mondays because the schedule exists, not necessarily because the kidney demands it at that exact moment.
Exactly. And LIBERATE-D is asking the question, what if we just stopped? What if we waited for the patient to force our hand? But before we get to the p-values, and I know you have a lot to say about those p-values.
Oh, I do.
I want to understand why we are stuck in this loop. Why is thrice weekly the religion of nephrology?
It is a religion, isn't it?
Yeah.
And like a lot of traditions in medicine, it started with heroism and ended up as, well, dogma. The editorial by Dr. Sushruth Waikar that came with this paper does a brilliant job of deconstructing that history. He takes us all the way back to the 1940s.
The Willem Kolff era, the pioneer.
Right. But you have to really picture what dialysis was back then. This wasn't a sleek machine with a touchscreen and, a million safety alarms. Kolff was working in Nazi-occupied Netherlands. He was building these things out of sausage casings and wooden drums. His first successful patient was a 67-year-old woman, and the session lasted 11 hours.
11 hours. I complain if the dialysis nurse runs 15 minutes late. Imagine the nursing documentation for an 11-hour run.
It was a metabolic exorcism.
Yeah.
I mean, it was a massive traumatic physiological event. You didn't do that casually. You did it because the alternative was immediate death.
Okay, so a last-ditch effort.
A total last resort.
Yeah.
Then you fast forward to Belding Scribner in Seattle, the guy who invented the shunt that made chronic dialysis even possible. His first chronic patient underwent a 76-hour initial session.
That's more than 3 days. That's an entire weekend on a machine.
Right. It really puts our modern 4-hour run into perspective. But here is where the logic drifted. Over decades, as the machines got safer and the membranes got more efficient, we standardized the process for end-stage renal disease, ESRD.
Right. For people whose kidneys are gone for good.
Exactly.
Yeah.
We found that for a patient with zero kidney function, 3 days a week was the sweet spot. It balanced, toxin removal with quality of life.
And that makes perfect sense for ESRD. The kidney is gone, it's scarred down, it's not coming back. You need a replacement schedule because you, the machine, are the organ now.
But then we did the thing medicine always does. We copy-pasted. We took the prescription for dead kidneys, ESRD, and we applied it to stunned kidneys, AKI. We assume that the recovering kidney needs the same rhythmic cleaning as the dead kidney.
And that's the flaw, because Mr. Martinez's kidney isn't dead. It's essentially in a coma. It's trying to wake up, and every time I put him on the machine, I might be slapping it back to sleep.
We call it dialysis-induced kidney injury now. It's a paradox. The treatment for the failed organ might actually be prolonging the failure. We've spent the last decade debating when to start. Remember the START-ACI trial?
Oh yeah, earlier is better. Which
Yeah.
turned out to be completely wrong. We learned that rushing in doesn't save lives, it just exposes people to risks they didn't need.
Exactly, so the pendulum swung. Now, LIBERATE-D is pushing that pendulum even further. It's not just don't start early, it's stop sooner.
The editorial had that great modification of the mnemonic. We all know AEIOU for starting dialysis. Acidosis, electrolytes, ingestions, overload, uremia.
Waikar suggests it should be AEIOU and sometimes Y. As in, why are we doing this run today?
So let's look at the why. This trial, LIBERATE-D, Liberation from Acute Dialysis. It's a randomized controlled trial published in JAMA in 2025. What was the setup?
Well, the core question was simple. Does a conservative strategy, basically a wait-and-see approach, lead to faster kidney recovery compared to a conventional, scheduled dialysis?
Okay, now, before we even talk about the intervention, I need to scream something from the rooftops. The population. This is where most people will misinterpret this study. If you take this protocol and apply it to the wrong patient, you could kill them.
That is not hyperbole. You absolutely have to look at the exclusion criteria first. They enrolled adults with AKI requiring dialysis who had been on therapy for at least 24 hours. But the absolute hard stop was hemodynamic instability.
Let's define that, because stable in the ICU is a pretty relative term.
It is. But in this study, stable meant 0 vasopressors. If the patient is on a whiff of Levophed, even 0.02 mics per kilo per minute, they are excluded. Out.
Okay, so no pressors at all. What else?
No mechanical ventilation via an endotracheal tube. A track collar is okay, maybe high flow is okay, but if they are intubated and fighting a vent, they are out.
That cuts out, what, 60% of my ICU census on any given day?
At least. But think about why. When a patient is in septic shock, on pressors, fighting a ventilator, their metabolic rate is through the roof. They are catabolic engines. They're breaking down muscle, generating acid, and creating nitrogenous waste at a rate that a wait-and-see strategy just cannot handle.
Right. You can't watch and wait if the potassium is rising by 1 point every hour because of rhabdo or, massive catabolism. You'll get behind fast.
Exactly. So this study is strictly for the recovery phase. This is Mr. Martinez on day 10, eating his Jell-O, not Mr. Martinez on day 1, crashing from sepsis. The authors were looking for patients who had passed the storm but were still kind of stuck on the boat.
Okay, so we have our stable cohort. They randomize them. One group gets conventional care standard Monday, Wednesday, Friday dialysis. The other gets the conservative approach. Define conservative for me. Is it just ignore them until they code?
No, it's active surveillance. The protocol was dialyze only if indicated, but the indications were pushed pretty far. You could say the safety net had some large holes.
How large? Give me the numbers.
All right, let's look at the triggers. First, BUN. They waited until it was greater than 112 milligrams per deciliter.
112. I get twitchy when the BUN crosses 80. 112 feels like we're inviting uremic encephalopathy to the party.
It's high. But clearly, the investigators felt it was not lethal. Then potassium. They allowed it to go up to 6.0 millimoles per liter, or even higher if there were no ECG changes and you hadn't maxed out medical therapy.
That's the key phrase, medical therapy. This isn't just watching the K rise with a bag of popcorn. It's aggressive binders, loop diuretics, maybe even some albuterol if you're getting desperate.
They were buying time. The whole point of the conservative arm was to use every tool in the pharmacy to avoid using the machine.
Okay, what else?
They also allowed the pH to go down to 7.15.
715 is a deep acidosis. Most intensivists see 7.20 and start, reflexively calling the dialysis nurse.
Right. And finally, volume. This one is interesting. The trigger wasn't just edema or positive fluid balance.
Yeah.
It was pulmonary edema causing hypoxemia. And they defined that as needing more than 50% FiO2 or more than 5 liters of O2 via nasal cannula.
So if they have crackles at the bases and their ankles are swollen like balloons, but they're satting 95% on 2 liters, you sit on your hands.
You sit on your hands or give a big dose of Lasix.
Yeah.
But you do not wheel in the dialysis machine.
Got it. And the control group, the conventional arm.
This is where the controversy starts, I think. The control group was on a strict schedule, thrice weekly. But they were also forbidden from stopping dialysis until the kidney proved it was ready.
Proved it how?
They needed a calculated creatinine clearance greater than 20 milliliters per minute, or urine output greater than 1 liter per day without diuretics, or 2 liters with them.
See, that feels artificial to me. In the real world, if Mr. Martinez makes 500 cc's of urine and looks good, I might just skip a session to see what happens. But this protocol forced the control group to keep dialyzing until they hit those hard targets.
Which brings up the big possibility. Was the conventional arm actually the harmful arm? Were they over-dialyzing not because it's standard of care, but because the study protocol locked them into this rigid, unforgiving schedule?
It's the unnecessary continuation theory. If you dialyze someone every other day, you are actively removing creatinine from their blood. You are masking the signal that the kidney is working. You can't see the natural drop because you keep washing it out.
It's like looking for a fire while you are spraying the house with a fire hose. You have to turn off the hose to see if it's still smoking.
All right, let's get to the numbers, the results. I saw the headline. 64% recovery in the conservative group versus 50% in the conventional group. That is a 14% absolute risk reduction.
It is.
In critical care, we usually throw a party for a 3% mortality benefit. 14% recovery is a landslide.
It looks like a landslide. The unadjusted p-value is 0.04. That's a statistically significant win.
Yeah.
You can almost hear the champagne popping in the author's office.
But you're not drinking the champagne. I can hear it in your voice. You're being the buzzkill.
I am the designated driver of data. We have to look at the adjusted analysis. And this is the part of the deep dive where listeners usually zone out. But stay with me, because this determines whether you should change your practice or not.
Why do we need to adjust? It's a randomized trial. Randomization is supposed to fix everything, right?
In a perfect world with 10,000 patients, yes. Randomization spreads the bad luck evenly. But this study had about 110 patients per group. It's a small study.
Okay.
And when the sample is that small, the coin flip doesn't always work out perfectly. It turns out the conventional group might have been just a little bit sicker at baseline, maybe a little older, maybe slightly worse creatinine starting out. The groups weren't perfectly balanced.
So the table wasn't perfectly level.
Exactly. So the statisticians run a model where they mathematically level the table. They adjust for things like age, sex, race, and baseline GFR. And when they did that, the signal faded.
The p-value went to 0.15.
Which, by the strict laws of statistics, means not significant. It means we cannot rule out the possibility that the difference we saw was due to chance or those baseline imbalances.
So is the 14% difference a mirage? Do we just ignore it?
Not necessarily. You call it a signal. It's highly likely that there is a real biological benefit there, but the noise of the small sample size drowned out the statistical proof.
Yeah.
And then there's a fragility index.
The editorial mentioned this. The fragility index was 0.
Is 0.
Yeah.
That is the lowest possible number. It means that if one single patient in the conservative group had failed to recover when they did, the unadjusted p-value of 0.04 would have jumped above 0.05 and become non-significant.
That is terrifyingly thin. It's like standing on a sheet of ice that's 1 millimeter thick.
It is. It tells us that this result is not robust. It's precarious. So you cannot walk into the ICU tomorrow and say, science proves we must stop dialysis. The math just doesn't support that word prove.
But, and here's the big but for me, even if the recovery data is statistically fragile, the workload data is rock solid.
Oh, absolutely. That's not even a question. The conservative group got half the dialysis. The median was 1.8 sessions per week versus 3.1 sessions per week in the conventional group.
Stop and think about that. Even if recovery rates were identical, even if there was 0 difference in the primary outcome, you just saved 50% of the resources, 50% of the nursing time, and 50% of the cost without harming the patient.
And you saved the patient from the hypotension. This is the mechanism we need to discuss.
The safety signal.
The hypotension signal was clear. There were 97 events in the control group versus 69 in the conservative group. That's not statistical noise, that's just mechanics. If you hook someone up to a machine less often, you drop their blood pressure less often.
And that brings us right back to the mechanism of injury. We think dialysis is cleaning, but the kidney might experience it as trauma.
Every single hypotensive episode, even a drop in MAP for 15 minutes, is an ischemic hit. The kidney is trying to regenerate tubular cells. It needs steady perfusion. When we dialyze and pull fluid rapidly, we cause stunning. You're basically punching the kidney while it's down.
So by backing off, we aren't just saving resources. We are providing hemodynamic stability. We are giving the tubular cells a quiet, well-perfused environment to regenerate.
Precisely. So the takeaway isn't, we prove conservative is better. The takeaway is, conservative is safe, it uses fewer resources, and it likely helps recovery by avoiding harm.
It's a classic case of less is more, or at least less is just as good and a lot cheaper and easier on the patient.
I would absolutely agree with that.
I want to take a moment here for our Teach the Fellow segment. We touched on the fragility index and the whole adjustment thing, but let's formalize it. If I'm a fellow presenting this paper at Journal Club tomorrow, how do I explain the fragility index without sounding like I just read Wikipedia 5 minutes before?
Okay, here is the pitch. The fragility index is a stress test for a p-value. It asks a simple question. How many events would have to swap from one group to the other to break the statistical significance?
Okay.
If the number is large, say 40, it means the trial is robust, it's solid. You could have errors in data collection or patients lost to follow up, and the conclusion would probably still hold.
Like a suspension bridge with a lot of extra cables.
Right. It can handle some stress.
Yeah.
But if the fragility index is 0 or 1, it means the result hinges on a handful of patients. It means the p-value of 0.04 isn't a truth, it's a maybe. It warns you to be humble about the result.
Humble. I like that. And for the adjusted analysis, why do editors and reviewers care so much about the pre-specified adjusted model?
Because it protects us from confounding. In a small trial like this, you might accidentally, just by the luck of the draw, have the healthier patients end up in the treatment group. If you don't adjust for that, you might credit the drug, or in this case the strategy, for a benefit that was actually just caused by the patients being a little bit younger or having better baseline kidneys to begin with.
So the adjusted analysis is the truth serum.
In a way, yes.
Mm.
It strips away the luck of the draw and tries to level the playing field after the fact.
Mm.
And in this case, when the truth serum was applied, the result became non-significant. That doesn't mean the effect isn't real, but it does mean we haven't proven it beyond a reasonable statistical doubt.
Okay, let's move to the most important part of this deep dive. Section 6. So what do we do Monday?
This is where the rubber meets the road.
I'm walking into the unit. I have Mr. Martinez. He fits the criteria. He's stable, off pressors, eating his Jell-O. How do I operationalize LIBERATE-D?
The mantra needs to change. It goes from Monday, Wednesday, Friday to reassess daily.
So no more standing orders, like dialysis MWF until DCD.
No. The order for dialysis should expire every 24 hours. Every single morning, it's a new decision.
And how does the conversation go with the nephrologist? Usually it's a nod in the hallway. Dialysis today. Yep. And that's it.
It needs to be a script change. It should sound something like this. Hey, Mr. Martinez is stable. His potassium is 4.8. His pH is 7.32. He's not overloaded from an oxygen standpoint. Can we trial holding dialysis today with close monitoring?
Can we trial holding? I like that phrasing. It sounds active. It sounds collaborative. It implies we have a plan if things go south.
And you need a plan. This is not doing nothing. This is active management. Let's talk about the nurse's role in this.
The nurse is the early warning system. If we aren't dialyzing, we are watching.
Exactly. They need to be watching trends. Strict I's and O's. Is the urine output picking up? Even a little bit. If he makes 20 cc's an hour for 4 hours, that's almost 100 cc's. If you send him to dialysis, you might miss that signal entirely.
And weights. We are terrible at daily weights in the ICU. But if we are managing volume without a machine, we absolutely need accurate daily weights.
And pharmacy. This is huge. If we aren't dialyzing, we lose our potassium safety net.
Right. If the K creeps up to 5.8, the knee-jerk reaction is dialyze. But the study says we can and should manage that medically first.
Exactly. The pharmacist should be proactive. They should be looking at the labs and saying, his K is 5.5. Should we start Lokelma? Should we add a loop diuretic? We use the meds to buy time.
And the respiratory therapists, they are watching the oxygen.
Yep. The study trigger was needing more than 5 liters of O2 or 50% FiO2. That is a high bar.
It is. I think a lot of people in practice would dialyze for 4 liters if there were crackles on exam.
But if they're satting 94% on 3 liters, that is not a trigger to dialyze according to this protocol. That is a trigger to give Lasix. Or just wait and watch.
What about ultrafiltration alone? The study mentioned this as an option.
Yes, and this is a key part of the conservative strategy. If the trigger is only volume-like, their potassium is fine, their acid is fine, but their lungs are getting a little wet. The study recommended skipping full dialysis and just doing UF. Just remove the fluid.
Why is that better?
It's gentler. You aren't stripping solutes. You aren't shifting osmolality as rapidly. And crucially, you aren't removing the creatinine, so you can still track the natural trend of kidney recovery.
It's using the scalpel instead of the chainsaw.
That's a really good way to put it.
So we have a plan. We reassess daily. We use medical management aggressively. We accept ugly numbers like a BUN of 100 as long as the patient is clinically safe and asymptomatic.
And we watch like a hawk for the bailout criteria. If they start desatting, if they get confused from uremia, we bail out and we dialyze. We don't try to be heroes.
Let's talk about the endpoint again for a second. In the study, more than 35% of the conservative group never needed another dialysis session after randomization.
That is the stat that sticks with me the most. 1 in 3 patients were done. They were liberated immediately.
Imagine Mr. Martinez. In the conventional arm, he spends Monday attached to a machine for 4 hours. He gets hypotensive. He feels washed out. He misses physical therapy. In the conservative arm, he does PT. He walks the hallway. He eats lunch. And maybe 3 days later, his creatinine starts to drop on its own.
That is the patient-centered victory right there. Even if the p-value is 0.15, that patient experience is undeniably better.
I want to wrap this up with our closing synthesis. We've covered a lot of ground history, stats, physiology, practice change. What are the 3 things our listener needs to put in their pocket and take to rounds tomorrow?
Okay, takeaway number 1. Less is probably more. For hemodynamically stable AKI patients, and I have to repeat, stable a wait-and-see strategy appears safe, and it significantly reduces the treatment burden.
Takeaway number 2.
Protect the recovery. Fewer dialysis sessions mean fewer hypotensive episodes. By holding back, we are avoiding these ischemic hits to the kidney, allowing it to heal faster, or at least allowing us to see the healing sooner.
And takeaway number 3, the big warning label.
Know the limits is a red box warning. Do not apply this to unstable, shocked, or ventilated patients. Do not apply this to hyperkalemic emergencies where medical management has failed. Stick to the AEIOU triggers strictly. This is for the tail end of the illness, not the beginning.
Solid. Now, I always like to leave the listener with a provocative thought, something that wasn't fully answered in the paper. What's yours?
My question is about the long game. We have 90-day data here, which is great, but what about 1 year, 5 years? Does this gentle approach lead to better CKD outcomes down the line?
Meaning, if we avoid those hypotensive hits now, does that mean Mr. Martinez is less likely to end up on chronic dialysis in 2030?
Exactly. We know that AKI leads to CKD. Is that progression inevitable, or is it partly iatrogenic because we keep stunning the kidneys during this delicate recovery phase? If active surveillance preserves nephron mass, the 5-year data could be even more impressive than the 90-day data.
That is the holy grail, right? Does acute management change chronic destiny?
We don't know yet, but this trial gives us a very strong hint.
And my provocative question is about the triggers. Are we still being too conservative even in the conservative arm? Could we tolerate a pH of 7.9 in an asymptomatic patient? Could we tolerate a BUN of 1 in 30?
You want to push it even further?
Why not? The body is resilient. Maybe we are still intervening too soon, even with these liberalized criteria.
Let's wait for the next trial for that one.
Fair enough. Well, this has been a fascinating look at how doing less might actually be doing better. It really challenges the autopilot nature of modern medicine.
It reminds us that the machine is a tool, not a master, and that the kidney wants to heal if we just give it a little space.
I'm going to use that on rounds tomorrow. The kidney wants to heal, let's give it some space. Thank you for breaking this down with me.
Always the pleasure.
If you found this helpful, share with a colleague, subscribe so you don't miss next week's study, and send us your next paper.